I'm a practicing gynecologist in Boise, and many of my patients really struggle with the decision of using vaginal estrogen. And I'm just wondering I know the data is a little muddy on vaginal estrogen alone and recurrence, and I would just love the experts panel on how I can better educate them. It's a big choice for women whether to have appropriate vaginal health for a healthy sexually active woman, but many are too frightened to use it because of breast cancer reoccurrence.
So you're specifically referring to women who have had a prior diagnosis of
yes,
breast cancer?
I'm talking solely on breast cancer survivors.
Fine.
And,
I'm going to take a stab at that one myself because I also have boards in endocrinology, and this is a great interest of mine. There is no question whatsoever that Premarin cream will absolutely result in some increase in circulating estrogens. There's only one small randomized trial done in Sweden, to my knowledge, which was terminated for systemic Premarin in women who had had breast cancer, and was terminated prematurely because there were too many recurrences. Whether or not the doses that you can achieve with vaginal use of estrogen are such that they could stimulate a breast cancer were it there aren't absolutely established, but likely they are good enough, because breast cancers, as has been the work of Kent and others, develop over time an ability to be particularly avid sponges of estrogen, so that as the levels get lower, they get to function at those lower levels, and that's quite worrisome. However, everything in life is a trade-off. If you just simply avoided risk, you wouldn't ski, right? I mean, you wouldn't. I mean, we all make decisions that are trade-offs. So you'd have to look at that in the context of a woman in terms of A, what is her actual risk of recurrence? Perhaps it's rather low. You have to also say, have you tried other non-hormonal means that may sometimes work better or effectively? And thirdly, of course, you have to just be an advisor as to quality of life, in my view. And people can choose more dangerous things because they'd rather be dead than not have a happy sex life. I mean, I don't mean that in the slightest bit ironically. I mean that just is an absolutely serious comment. We all make trade-offs like that. So I think it's complicated. But I think if you just want the objective answer, are you more likely than not, in my view, to increase the risk of relapses? A few? Yes. Ken?
Yeah, I would differentiate into different groups of women. If the woman's on tamoxifen, no problem. Tamoxifen works in premenopausal women who have sky-high estrogen levels. So the estrogen that's absorbed, and it is, even from things like Estrogen and Vagifem, although we don't know, if that low amount that's absorbed is going to be deleterious, but I'm not sure we're ever going to do a trial to figure it out. But if you're on tamoxifen, I have no problem giving as much vaginal estrogen as you want, because tamoxifen works in young women who have sky-high estrogen levels. On aromatase inhibitors, where this is a bigger problem, that's the issue.
I think that's a great modification.
So, and I would add a little further optimism. We are going to know. There's a small trial that was reported in a handful of women given Vagifem at the European dose that showed a bump in serum estrogen levels, which was concerning. But it was a very, very small number, and the vaginal wall reepithelializes with treatment, so that paradoxically there could be some decline in absorption. There is a prospective study in women on aromatase inhibitors right now where they get baseline bloods drawn, they take Vagifem, and their serum estrogen levels are actually monitored for 2 years. And the obvious point is that if there's a brief blip in the estrogen and then it falls, maybe we don't have to worry so much. If there is persistent elevation, we may have to worry a bit more. And it's using the lower dose, recently approved Vagifem dose. So I think we may be able to answer this question.